Dr. Rolando Monteverde Diaz, and I'm going to be working in collaboration with Dr. Ivan Cavante, Dr. Alejandro Dominguez, and Dr. Pedro Valdez. Today, we're going to be presenting an unusual case of ACS-like presentation due to an anatomical variant in the setting of paroxysmal atrial fibrillation. We begin by talking about myocardial bridging, which is generally regarded as a benign condition, involving one or more coronary arteries, which travel through the heart muscle instead of lying superficially. We will be focusing on the less common but severe events that can ensue, which include cardiac ischemia, severe arrhythmia, and sudden cardiac death. We begin by describing a 50-year-old male patient with no known past medical history, which presented to the emergency department for acute onset substernal chest pain, with associated palpitations that began 6 hours prior. He describes the pain as non-radiating, alleviating with pain and nitroglycerin, and occurring at rest with no aggravating factors. Physical examination revealed an irregularly tachycardic rhythm on auscultation, with no murmurs appreciated. Lung fields were clear to auscultation bilaterally. There were no signs of jugular venous distension, ascites, or peripherally pitting edema. Electrocardiogram revealed an irregular rhythm, consistent with new onset atrial fibrillation, at a rate of around 150 beats per minute, and lateral ST depressions consistent with ischemia. As we can see on the left lower corner of this presentation, the follow-up EKG showed appreciable signs of ischemia with ST depressions on V4, V6. Troponins were initially undetectable, but later on increased to 3.86 within 7 hours, peaking at an astonishing 31.1. Echocardiography and angiography both demonstrated appropriate ejection fractions, which were above 55%, with no evidence of wall motion abnormality. This patient was taken for emergency cardiac catheterization. In lieu of showing occlusive disease or ruptured plaque, the catheterization unveiled myocardial bridging in the mid and distal portion of the left anterior descending artery. As we can see on the left side of the presentation, the image labeled B shows on systole systolic narrowing as seen on the mid and distal LAD, as evidenced by the arrowheads, while on diastole, no compression is evidenced. This patient was successfully transitioned to oral diltiazem 120 mg daily, achieving sustained rate control, and he remained symptom-free. The remainder of his hospital stay was uneventful, and he was discharged on cardizem 120 mg PO daily, aspirin 81 mg daily, and atorvastatin 40 mg daily. We continue our discussion as myocardial bridging is an uncommon cause of myocardial ischemia, yet it should be considered in the setting of paroxysmal atrial fibrillation. This case emphasizes the role of arrhythmia in patients with myocardial bridging, further supporting the extent of diastolic blood flow compromise that occurs during hyperdynamic myocardial contractions. Additional mechanical compression during systole includes a retrograde intracoronary flow that further decreases perfusion within the coronary artery. Tachycardia also leads to a shortening of diastole, causing reduced ventricular filling, resulting in decreased coronary flow, leading to myocardial ischemia, as noticed in our patient who had presented with AFib with rapid ventricular response. Conservative management in rate controlling with calcium channel blockers provided immediate relief for symptoms, further supporting current standard of care. Surgical management is only reserved for patients with recurring or intractable symptoms with insignificant response to conservative medical management. Interventions including coronary stent, supraarterial myotomy, and coronary artery bypass grafting. Reports of severe cardiac events are rare, but myocardial bridging should not be forgotten, as it remains a cause of acute cardiac ischemia, severe arrhythmia, and even sudden cardiac death. I would like to give my thanks to Palmetto General Hospital and to you all at the ACP for your consideration.